Senior Consultant Family Physician, and Dr. Sanand Akrimanan, President of the Sri Lanka College of Obstetricians and Gynecologists, will now take over the proceedings.
Good afternoon, ladies and gentlemen. Let me welcome you all for our next segment. To make this afternoon interesting, we have a joint symposium with the College of General Practitioners of Sri Lanka. The President and the Council of the College of General Practitioners of Sri Lanka congratulates and extends their best wishes on celebrating the Silver Jubilee Academic Sessions of the Menopause Society of Sri Lanka. This symposium is all about bridging the gap in menopausal care. Majority of the patients suffer in silence. Two main important icons who can identify this are their gynecologists or their family physicians. I think if we work together and share our expertise and experiences, we definitely could improve to bridge this gap to help our patients. Our focus this afternoon will be on integrating rational hormonal use, holistic approaches, and bone health management. For this task, I have with us three eminent speakers, Dr. Sumit Varnasurya. Can I invite them on stage, please? Dr. Sumit Varnasurya, Dr. Maitri Rupasinghe, and Dr. Indika Karunamani.
Good afternoon. To start the joint symposium, Dr. Sumit Varnasurya is going to talk to us about prudent general practice in midlife and beyond, concerns and cautions from a clinician's point of view. Dr. Sumit Varnasurya, the senior consultant obstetrician and gynecologist from Base Hospital, Damadevi, Sri Lanka. He is a fellow in minimal access surgery, life member Sri Lanka Menopause Society, Regional Academic Activity Coordinator, Menopause of Sri Lanka from 2010 to 2018, Council Member Sri Lanka Menopause Society 2014, 15, 23 and 24, and Assistant Secretary Menopause Society of Sri Lanka 2025, 2026. So he's going to talk about prudent general practice in midlife and beyond, concerns and cautions from clinical point of view. Over to you, Sumit.
Thank you very much. Actually, I am delighted to share this occasion with the College of General Practitioners. Thank you very much for all for the excellent coordination, including our chairman and my colleagues from the College of General Practitioners. So my topic is, I'm just going to keep things simple. And if you keep, simple things can go a long way for the clinician. So basically I'm sharing my experience. I'm not very sure, this applies to all of you, probably you all already know what I'm going to say, but I work in the outstations and there are general practitioners under different categories. So this is what I see and I'm just sharing and giving some insight, so I hope the message would go on to them as well. So good practice at primary care level, especially GPs are first line of contact, and proper counseling and early referral would make things very easy to the specialized center. And things that we do not expect is if at primary care, if there's any intervention that would prevent with the further management at the specialized center, or probably hamper the upcoming management protocols, or probably doing more aggressive treatment without monitoring. By the time patient comes to the specialized center, things have gone a little bit out of hand. So I'm just telling, giving some advice. So I'm going to talk on three things. One is the blind use of northeastern in abdominal uterine bleeding. Other one is excessive use of clomiphene citrate in fertility patients without further investigations. And the last one is about the HRT. I know a lot of people would like HRT, but they are a bit scared. As the saying goes, asai bhaya. Right? So when they come to the GPs, if you know the real situation, you can just explain, okay, this is what has happened. So I'm going to rush through this because I'll keep to the time. I thought I got 20 minutes. So blind use of northeastern in abnormal uterine bleeding. Basically, as a rule of the thumb, I mean these are not exact figures. If there's endometrial bleeding, majority would be, about 90% would be for functional causes like anovulation. So it doesn't matter whatever you do. But sometimes about 90% out of the rest, that is 9%, could be of benign pathology. Again, intramural fibroids, polyps, and especially iatrogenic, and endometrial hyperplasia without atypia, which might revert back to normal or which might progress. That's fine. But remaining 1%, you might have malignancies. So it's just not one entity. And if you give northeastern in abnormal uterine bleeding, what happens is when it comes to a specialized unit, you do endometrial sampling, the report comes as, report is compatible with use of exogenous hormone therapy. I hope a lot of people would have got that report back. You use due to exogenous hormone therapy, but you don't get a proper reading of the endometrial sampling because it alters the endometrium. So that will hamper. The other thing is, sometimes it's again, if I use a singular term, you give northeastern and the symptoms settle and the patient is very happy. And she says, okay, this is the end of the story, I don't need any further treatment. The other one is, if you give northeastern, say suppose in 7 days or 21 days, moment you stop it, there will be withdrawal bleeding and again there will be torrential bleeding. So again, aggravating the symptoms after some time, you just buy some time. So in the first place, as a first line northeastern, it won't work. The other problem is the patients, some patients, being too smart, they think, okay, with this tablet, it responded, so they'll go on taking it over and over and over again without a repeat prescription, but the pharmacist would be jolly well handing over northeastern. And after about 9-10 months, they will come back with some other pathology. So giving northeastern first line is not the ideal choice. That's what I want to say. And also, in addition, there can be even extrauterine causes for bleeding PV, like estrogen secreting tumors, ovary, adrenal, or hormonal imbalance, hormonal causes like hypothyroidism, hyper. And more sinister is there could be other carcinoma like cervical, vaginal, or vulval carcinomas. Because I had a very bad experience at my place. Sorry to say, it was done by a family physician. He had been prescribing northeastern for about 3 months. With no response, finally the patient on her own came to my ward, and on examination, it was massive CA cervix. And when we analyzed it, CT scan, it was stage 3. So she has wasted a lot of time, and actually I had to convey the message in very good terms to the colleague, and he didn't take it very nicely, and I had problems, but afterwards I invited him for a couple of drinks, and then things are okay. But anyway, that's what happens. But anyway, the patient is the one who suffered. So first line use of northeastern is not the ideal management. It's like doing a blood picture prior to blood transfusion. I mean, you can give blood transfusion after the investigation. Same thing, after endometrial sampling, you can give northeastern, but not before that. Other thing is management of fertility problems. Again, at the primary care level, GP is in a good wicket to get a proper history and counseling. Make sure the patient has had rubella immunization, because rubella, after all the hard work, patient gets pregnant, and if she gets rubella, there's a 50 to 90% chance of the fetus getting lethal congenital anomalies. Periconstruction folic acid will prevent neurotic defect, so you can do a checklist. And knowledge about fertile period. I mean, still, even at this age, people don't get it right. Very recently, a woman came, husband is, I think, from the police. She said the fertile period is 7 days after cessation of menstruation. And I said, this is wrong, this is the whole problem, and the policeman was very happy. He knew that what had gone wrong. It's a simple thing. And also, sometimes the mother-in-law comes with the daughter-in-law, frowning at her all the time to check, finally, her own son is azoospermic. So you got to check the male factor, seminal fluid analysis, got to screen for the medical problems like thyroid, diabetes, and antiphospholipid syndrome, and social problems like husband working far away, not home during the fertile period, and also the age factor. Usually people come, say women in early 40s with their second marriage, and then now they want to conceive. So again, you have to say that the response might be a little bit low. I mean, a lot of things you can do at the primary care level. Also, if the woman is obese, polycystic ovaries, you can ask them weight reduction, metformin, and there are a lot of things you can do. And also, you can give some micronutrients without blindly going into clomiphene citrate. So indiscriminate ovulation induction without monitoring might, without assessment of the couple and without lack of facilities, could go into treatment failure or expose the patient into dangers. Like inefficient treatment, there might be clomiphene resistance, there might be male factor, there might be tubal factors, there could be various other things. So just going on with clomiphene over and over, it doesn't work. So there's no point giving it. Other thing is, it might expose the patients to, one is high risk multiple pregnancies. I mean, there can be increased perinatal mortality rate. You are exposing the mother to more maternal risk, and also a big problem with the pediatricians, because I mean, you know, if there's just twins in the PBU, I mean, they will send message to say, okay, there are twins, till those twins are weaned off, don't send. I mean, just imagine if there are 3 or 4. And also these are extreme premature babies. We don't know about the survival as well. So you are clogging the pediatric team, the neonatologist, and the ventilators by with multiple pregnancies. And also ovarian hyperstimulation syndrome. They don't usually use the scans. They just give clomiphene citrate. So if it is mild, mild is okay. Moderate might be involved. But if it is occasional, rare, you get severe OHSS, ovarian hyperstimulation. And the patient has to be monitored in an intensive care setup. It's just like a rough estimate is like dengue shock syndrome. I mean, fluid is going over, and it's a life-threatening condition as well. So you can't use clomiphene citrate blindly. The last one is the ovarian carcinoma. Little bit of increase of ovarian carcinoma, especially women who had not responded to clomiphene citrate. And what happens there is, I mean, as you know, the oral contraceptive is it's preventive of ovarian CA because it stops mitosis. But clomiphene, we promote mitosis. And then the woman gets exposed, and there is a connection. I mean, in the literature there are controversy. But anyway, you expose this. I can remember very well when I was a medical student. Sir was there, but he has just gone. I think Professor Wilfred Perra. When we opened up, the woman had ovarian carcinoma. And I can remember whoever the consultant was telling, look, she has taken clomiphene citrate right throughout. Her husband was a airman, Air Force officer. Those days he was out on operational duties. And just blindly taking clomiphene citrate, and I can still remember, so this could have been a cause for this CA ovary. So please remember, blind use of clomiphene citrate can be harmful. So you need to do proper follicular tracking as well. The last one is, it's not a bit of a controversy, I'm just telling, highlighting some fact. You know, hormone replacement therapy, a lot of people are scared. They might ask, some people, say, let's go. But otherwise, some people are scared. So when they come to you and ask, is this good or bad, or there had been some rumors about HRT doing nasty things, what are you going to say? So the whole story is, in a nutshell, menopause versus andropause actually is a very big topic, very interesting. I have a nice presentation running about 1 hour 15 minutes, it's not the time, with good looking ladies in their 50s and 60s. If the College of General Practitioners invite me, I can do a separate lecture, but not right now. So what happens is, men versus women, menopause, the woman has the ova already ready-made. There's nothing new coming up. And suddenly, by about say late 40s, the stock get depletes, and there's no estrogen, full stop. In men, the decline of testosterone starts from late 30s and early 40s, and roughly about 1% per year. So the man can go till about 70 years, and it's a gradual decline. I can remember my mother telling, when it comes to growing old, women grow faster than men. So I mean, that was a whole saying. So this is the reason, and also traditionally, usually women marry men marry women quite younger to them. So this whole thing gets balanced. I mean, nowadays it's the other way around. It doesn't apply. So anyway, even from past, people would have noticed this. So what happens is, so in late 1980s, the technology was there. The mode of thinking was, okay, if something is deficient, supposing if you don't have insulin and having diabetes, you replace with insulin, you come back to normal. Same with thyroxine. So if you don't have estrogen, let's give estrogen from outside and you will be fine. And they did it and it worked wonders. Prevention of menopausal symptoms, loss of preventive of fractures, prevention from heart disease, prevention of memory decline, and a lot of things. And this took off very rapidly. And then in late 90s, there were these studies, HERS 1, 2, Million Women Studies, Women's Health Initiative, and they found HRT causes harm to women. And it was such a big panic, and women stopped taking, and a multi-billion dollar pharmaceutical field industries collapsed because of this. So how are you going to counsel the patient? So what happened was actually 1991 with WHI, they said there's an increase of heart disease, stroke, blood clots and breast cancer. In 1996, UK Million Women Studies, increased risk of CA breast, carcinoma breast, especially if you use both estrogen and progesterone, the increase is more. Especially there are rare causes where the breast carcinoma coexist with endometrial carcinoma, and if the breast carcinoma is positive for progesterone, even if you give northisterone, it might worsen. So that's another reason why you should not use northisterone blindly. And then the HER study is no benefit at all. So who would like to take? Nobody. But what happened is they did an analysis, and then they found in WHI the age group was recruited was 50 to 80 years, and all these casualties were around nearing 80s. I mean, you don't even without HRT, you don't expect ladies in that age group to live that long. So you should not be basically blaming the HRT for that. So there was a confounding factor. Other one is they were using conjugated equine estrogen and MPA, medroxyprogesterone acetate. So conjugated estrogen, equine estrogen is derived from horses. That might be good, do well for menopause horses, but not women, humans. So you are not using the ideal molecule. And also the medroxyprogesterone acetate, we don't have these tablets. We used to use this for simple hyperplasia. Now it's out of the market. It's not a very good progesterone as at present. You have the DMPA, but so the molecule is different, and probably the route of administration is different as well. And then finally the wrong interpretation of statistics. What they say was they used this Cox regression analysis. It says hazard ratio is 1.29 or 29%, which they were comparing 7 or I think it should be 8, around 8. 8 of 30 is 29%. But actually when you put the relative risk, 0.3 per 10,000 is 30 in the placebo. But with HRT it's 0.37, okay, the 7 is there, but that is 37. So you deduct by 10,000, at the end of the study, placebo group there are 9,970 women living, and with the HRT group still there are 9,963 without any problem. So only 7 difference, it's basically 0.07. So there's a confounding as well. Okay, I thought it was a 20 minutes, just give me 1 minute please. So with these statistics, so these studies are not the absolute truth. So finally the pendulum comes back. Initially thought it's very good, then bad. Now it's back to again it's good. There is more benefit than the risks. So all you have to do is you have to screen the individuals. That can be done by the GPs to exclude risk factors, and then start HRT as early as possible when the woman is young, not at 5 to 10, even right at menopause. That should be fine. Lowest possible dose, you can use alternate routes like transdermal or merinocoil, and use natural molecules and short periods of duration. And when to stop? When she's free of symptoms, or when the woman is ready to stop, or side effects, or when the risks go up. But when the HRT is stopped, you have to ensure all the risk factors go away along with the good factors. So with that, I will answer the questions at the end. I just want to say another story. When I was in the UK, I was traveling from London to Wales. I used to take the train, and one of my colleagues said use the bus just for the difference. And there was a lady next to me. She would have been about 60, and we had a chat. And I told her there was a war going back in Sri Lanka, and she said, yes, I can remember the Second World War. And when you mention Hitler, she shivers. I mean, she really remembers him. And then about British casualties coming across the channel, Then I was just wondering, hold on now, if she can remember all these things, she can't be 60, right? So I apologized myself and asked, how old are you? She said, I'm 85. I said, how come that? I'm using HRT. I said, HRT has to be used according to what we have been told. It has to be very short. No, I'm using it for 35 years. I said, my God, what will happen? I don't care. I have lived with HRT for 35 years. If I'm going to die because of HRT, fine, because I'm like this because of HRT. See you boy, took both the bags and just got down just like a young woman. So I don't know, those are the things that you need to, those are not in the books, but just think about it, and a lot of counseling and things has to be done. So all I have to say is, blind use of northeastern, just you have to think about it. Blind use of clomiphene, you got to think about it. And HRT, the whole story of this being good and bad is not the real one if you analyze it. So if I have problems, we might get enough time, so I will be happy to answer. Thank you very much.
Thank you, Sumit, for that thought-provoking talk. I think we can ask questions. If the audience has questions, we can ask at the end of the session. I think Dr. Thivan, please go ahead to introduce the next speaker.
Yeah, next I would like to call upon Dr. Maitri Rupasinghe. Dr. Maitri Rupasinghe is a distinguished family physician and an academic leader in family medicine. He is a senior lecturer and he is the head of the Department of Family Medicine and the Faculty of Medicine, University of California. Dr. Rupasinghe has significantly contributed to medical education as a trainer, examiner, a mentor across multiple postgraduate and undergraduate family medicine programs. Internationally, he serves as a visiting academic fellow at Western Sydney University. He also has authorized numerous peer-reviewed publications with many research interests. Currently, he holds key leadership positions in national professional bodies, including his current role as the Sensei-in-Chief of the Ceylon College of Family Physicians. Dr. Maitri, your topic, it will be on holistic non-hormonal management of menopausal symptoms in primary care, a practical approach for the general practitioners.
Thank you so much for those kind words. And I'd like to, at the onset, I'd like to thank the organizers for inviting me to talk in this August assembly. So good afternoon, esteemed colleagues. It is a pleasure to join you at the Sri Lanka Menopause Society Silver Jubilee session. Today, we'll explore practical, evidence-based options for non-hormonal management of menopause for GPs working in the community. As we begin, it is important to recognize that menopause management is evolving rapidly, as from the morning we heard about that. While hormone management therapy remains a cornerstone for some, many women are now seeking non-hormonal options driven by personal preferences, contraindications, or cultural beliefs. In this landscape of change, general practitioners have a pivotal role not only in initiating conversations but also in tailoring care to individual needs and guiding women through this transition with confidence and empathy, as we are the first contact. When discussing menopause management, personal preferences matters more than ever. Many women actively choose non-hormonal options, not just because of medical contraindications like breast cancer or cardiovascular risk, but also due to perceived safety concerns about hormone therapy. Some simply feel more comfortable with the natural or alternative approaches. As clinicians, it's essential that we respect these choices and offer evidence-based, individualized care that aligns with both their health needs and values. When we talk about menopause symptoms, vasomotor symptoms and urogenital complaints are among the most common and distressing. Hot flushes and night sweats can disrupt sleep and daily functioning, while vaginal dryness, pain during intercourse, and urinary urgency significantly impact quality of life and relationships. Whether hormonal or non-hormonal, our treatment strategies must focus on relieving these specific symptoms to truly improve well-being during this transition. When hormone therapy is not suitable or preferred, several non-hormonal options are available for managing vasomotor symptoms. Out of these, SSRI and SNRI, such as paroxetine, venlafaxine, and citalopram, have shown moderate effectiveness in reducing hot flushes. And also gabapentin and pregabalin, originally used for neuropathic pain, are also useful especially for night sweats. Clonidine, which has been used for years, though less commonly used now due to side effects, remains an option. Oxybutynin, which is usually used to treat overactive bladder, has been shown to reduce incidence of hot flushes. It is being used off license by some menopause specialists for this purpose. And now with the approval of fezolinetant, a newer molecule, a neurokine 3 receptor antagonist, we don't have it here in Sri Lanka. We are entering a promising new era of targeted therapy. Here it works in the brain at the hypothalamus. When prescribing non-hormonal treatment, dosing and precautions are key. If you are going to start paroxetine at 10 milligram daily. And if the patient is having some sort of mood disorder, you can even go up to 20. Remember, it should be avoided in patients with tamoxifen due to cytochrome enzyme inhibition. Venlafaxine is typically started at 37.5 milligram and can be increased to 75 milligram based on response. Gabapentin, helpful especially at night, is usually dosed between 300 to 900 milligram. You can give even in divided doses. Clonidine requires careful titration due to its side effects like hypertension, dry mouth, and also if you just try to withdraw it abruptly, sometimes there can be rebound hypertension as well. Oxybutynin, usual dose is 2.5 milligram twice daily with the option of increasing to 5 milligram twice daily. And also the new molecule fezolinetant is given 45 milligram once daily. But remember, as family physicians, always individualize the treatment and monitor closely for efficacy and side effects. Beyond medications, lifestyle and behavior therapies offer valuable evidence-based relief for many menopausal symptoms. Out of these, cognitive behavior therapy has shown consistent benefits, especially for mood disorders and hot flush management. And also clinical hypnosis. Now we have GPs who are trained in giving hypnosis. Bio-trained therapies may help reduce the intensity of vasomotor symptoms as well. And also acupuncture, though variable in evidence, is increasingly sought by women preferring alternative options. And simple interventions like regular exercise and relaxation techniques can improve overall well-being, sleep, and stress resilience. So these approaches may empower women to actively participate in their menopause care. Many women turn into herbal and dietary supplements, believing them to be safer alternatives. Isoflavones, soy products, and red clover, which are plant-based estrogens, have shown limited and inconsistent evidence for symptom relief. Black cohosh is sometimes used to relieve hot flushes, but these should be avoided in women with breast cancer due to uncertain estrogenic effects. And also sometimes you may meet a patient who is on St. John's wort, who is coming from overseas, often used for mood symptoms, but has some evidence that poses, that helps in hot flushes. But it has high risk of drug interactions, especially with antidepressants and anticoagulants. If you try to combine a medication with that, you should be careful. But note that it is crucial to educate the clients about these products and guide them with balanced, evidence-based advice as general practitioners. The other common symptoms observed in menopause are urogenital symptoms. Urogenital atrophy is often underdiagnosed, yet it significantly affects quality of life. Symptoms like, as I said earlier, vaginal dryness, burning, dyspareunia, urinary urgency are common, but many women don't report them. In our setting, of course, may be due to embarrassment or misconception that they are normal. Importantly, this condition affects all women post-menopause, not just those who are sexually active. So you have to, intervene you have to deal with all the women post-menopause when it comes to urogenital atrophy. So recognizing and addressing it early can greatly improve comfort, confidence, well-being, more than that, quality of life. When managing urogenital atrophy without hormones, we begin with lubricants and moisturizers as first-line treatment. Should be used regularly, not just during intercourse. They help restore vaginal moisture and reduce irritation. And also lifestyle changes like, we find women often who smoke in our setting as well. Lifestyle changes like smoking cessation can slow atrophic changes, while regular sexual activity, including non-penetrative sex, even helps maintain vaginal elasticity and blood flow. And also pelvic floor physiotherapy by a specialist, or sometimes, just simply doing Kegels exercise at home also plays a valuable role in improving pelvic muscle tone and bladder control. So these options offer a safe, effective pathway for women who can't or prefer not to use estrogen. New therapies are expanding for urogenital atrophy, especially for women who cannot use estrogen. One of the molecules is ospemifene, an oral SERM, is approved for treating dyspareunia and vaginal dryness. It acts on vaginal tissue and it spares breast as well. The good thing is that it won't affect the breast tissue. And also another emerging therapy is laser therapy like carbon dioxide and yak laser, which aims to stimulate collagen and improve vaginal elasticity and moisture. But remember, while promising, these interventions need more long-term safety and efficacy data, so patient counseling should reflect current evidence and availability. So you should update yourself on the current evidence as well. Now we find lots of patients with breast cancer. When managing breast cancer patients, special considerations are essential. Estrogenic or herbal agents should be avoided due to potential hormone sensitivity. Safe treatment options for symptoms include venlafaxine, gabapentin, clonidine, and also cognitive behavior therapy. For issues like vaginal dryness, always we should use lubricants to start with, lubricants and moisturizers as the first line before other interventions. And these approaches help provide effective symptom relief while minimizing the risk. So dear colleagues, as general practitioners, it's important to individualize non-hormonal management for menopausal women, considering their specific symptoms, preferences, and risk factors. And we have to set realistic expectations and help patients understand what non-hormonal options can and cannot do. And we have to monitor adherence to treatment like SSRI, gabapentin, or lifestyle interventions, and watch for any side effects as well. And don't hesitate to refer a patient to a specialist when the problem is complex and is unresponsive. This patient-centered approach ensures safe and effective care without hormone therapy. In conclusion, ladies and gentlemen, non-hormonal options for menopause management are expanding, offering safe and effective alternatives for many women. As general practitioners, we play a vital role in identifying suitable therapies, providing guidance and supporting long-term care, and also referring the patients to specialists. Most importantly, let's empower women by giving them informed choices so they feel heard, respected, and confident in managing this important phase of life. Thank you.
Maitri. We'll keep the questions for the last. So next I would like to call upon Dr. Indika Karunamuni. Dr. Indika is a family physician at the Family Practice Center, Department of Family Medicine, University of Sri Javadagura. He is the treasurer of the College of General Practitioners of Sri Lanka and also the secretary of the Faculty of Teachers of the college. He serves as an examiner for the MRCGP international exams conducted by the RCGP UK, and is actively involved in teaching and promoting evidence-based holistic primary care. Dr. Indika has an interest on bone health. Not only he focuses on the issue, but does a lot of health education in his primary care setting. His topic this afternoon will be on practical approaches to bone health management in menopause, a family physician's perspective. Over to you, Dr. Indika.
Good afternoon, everybody, and thank you, Dr. Tiwanka, for kind introduction. So, I will be sharing my experience as a general practitioner in providing osteoporotic care to our patients, both in academic and community settings. Osteoporosis is a silent disease, but the factors are loud. As you know, in early stages, osteoporosis, we don't know whether it's there or not. But we can't delay looking for it and treating it. On a positive note, I think GP has a role, a leading role in providing osteoporotic care. We have certain characteristics as general practitioners who are well placed to and available, accessible to our patients. We are the first contacts, and we are visited frequently. And we have already developed trust. In osteoporosis, patient not feeling anything, and patient is symptomatic. And if we are going to talk about that they have never heard about, this closeness is very important. So what can GP do? We can educate about bone health, and we can implement preventive measures in our patients, and when the time comes, we have to screen. And if you find that your patient is having osteoporosis, we have to initiate treatment. Osteoporosis is among the top 10 most important non-communicable diseases worldwide. So, how we can prevent it? As I told you, we can educate our patients. So there's a thing called osteoporosis, and we are looking at few years ahead, and then if we prevent osteoporosis, we can prevent a lot of complications. And we can include lifestyle modifications. As you know, lack of physical activity, one of the leading causes. And also nutrition, also very important. As general practitioners, we can discuss these even with young girls, because childhood nutrition is also very important in bone health. For you to have a stronger bone at the beginning, before your menopause starts, you should have optimal bones. So, other than the healthy nutrition, we can provide calcium and vitamin D supplements to our patients, especially after 50, in their menopause. And we should always have a follow-up plan with them. Let me explain further with this patient. I have a patient, she is coming regularly to see me for her high blood pressure management, and she is unmarried, and she lives in a boarding place. She is 55 years old now, and she had menopause at the age of 49. And I have told about osteoporosis to her, and I have initiated vitamin D and calcium supplements, because she is on her own. One day, if she gets weaker, she will have a lot of problems. So to avoid that, I have initiated vitamin D and calcium supplements, and also we have a plan to do DEXA scan in future. So all of you know that what are the screening guidelines. Even though we do not have any guidelines and protocols in Sri Lanka, we can adapt from other countries. But it always always should be selective in Sri Lanka. We don't have ample resources to do universal screening. Hence, I think that we are practicing we are selecting patients who are having high risk factors for the screening. So you can use these tools. FRAX is a clinical assessment tool, and it can be used without BND or with BND, and it estimates 10-year fracture risk. DEXA scan, you know that it measures BND, and in the hip and spine, it gives us T-score. Why we need this FRAX score? In simple terms, some patients, even though their BMD is very low, they don't get any fracture. And otherwise, there are patients who have in the osteopenic range, they develop fracture. So we need to consider other things. Even though BMD is a major factor, we need to consider. And thanks to Professor, I forgot the name. So there are Sri Lankan specific FRAX tool now, and also since the DEXA scans are limited in the public sector, especially, we can use this tool to see high-risk patients for the fractures. But there are barriers. There are patients factors and doctor factors. Especially, it's very costly initially doing investigation, and it involves a lot of money if you are going to treat. My practical approach is I have a clinical poster in the clinic to educate my patients, and also I tell my patients, when we initiate the things, our aim is to prevent fractures. But there won't be any immediate benefits for you. And if we do the screening, and if we find out that you are having osteoporosis, it might involve some additional healthcare costs for you. So I tell all of these things in preparation, telling them that we can do this test to prevent fractures in future. I have the privilege of using the DEXA scan in the university for those patients, and it is an added advantage, and that thing has given a lot of opportunities for me to learn about this subject as well. But for those who can afford, we definitely confidently should offer DEXA scan. Few practically important things, like we should stop calcium supplement before 24 hours before this scan, and also don't think that skeletal X-ray can detect. You have to have 30 to 40% bone loss to be seen in the regular X-rays. Also, if you are afraid of radiation risk with DEXA scan, is very minimal. It's actually around natural, if you expose to natural daylight, it will be the same in DEXA scan as well. So interpreting DEXA reports, you see the T-score in all the sites, and if any site is lower than -2.5, patient has osteoporosis. And carefully look at the lumbar spines, L1 to L4, and some degenerative changes can give falsely elevated things and making the average wrong, giving a wrong impression. So if there is anything in the T-score in the lumbar spines, neighboring lumbar spines more than 1 SD, you have to neglect that and count the average, calculate the average again, and go for your diagnosis. And it's also important to look at the Z-score, because if there's any deviation, if the Z-score is less than -2, you have to think about the secondary causes of osteoporosis. And it's also very important that you compare with previous reports, because any decline, you have to be very vigilant. And always you have to correlate with the clinical findings. For an example, like if the patient is having backache, DEXA scan won't show it, you will have to do an X-ray. So sometimes we get report asking us to exclude secondary osteoporosis. So these are the cases, like if there's unusually, if the osteoporosis is present in an unusually young age, below 50 years old, if there are multiple fractures, if there are the multiple fractures, if the fractures are in the unusual sites, and if the Z-score is less than -2, we will have to do further testing to exclude secondary osteoporosis. And also, like if there are any other red flags, any other symptoms, and if the patient is on other medications, we can count them as secondary osteoporosis and they need further assessment. So these are the tests. I have listed the basic test and tests that we would do if it is indicated. And mind you that most of these secondary causes wouldn't be visible. They will be mostly asymptomatic. So sometimes we might have to think about those when we get the reports. So these are the treatment guidelines. If the DEXA says T-score is -2 less than -2.5, we have to treat. And if the patient is having fragility fracture, it's a clinical diagnosis. You don't need to have a DEXA, and we have to initiate treatment. And osteopenia, and then that is where the FRAX tool is important. If the DEXA is showing osteopenia, and then FRAX score shows that hip fracture is more than 3%, and total fracture is more than 20%, go for treatment. And there are other things patients on harmful medications, also patient high risk, obviously very elderly patients, we might consider treatment. This is something I want to emphasize today, the therapeutic window of opportunity. Sometimes patients comes back to us after a fall and they get an injury, minimal trauma, but the treatment had not been started. Clinically, they are osteoporotic patients. So we have to, as general practitioners, initiate treatment. First, we are starting with basic vitamins and minerals, calcium and vitamin D, and then we will go for an anti-disruptive treatment. So as basic therapy, calcium and vitamin D collectively has been shown to be having significant effect in preventing and also enhancing the treatment effect of the anti-disruptive medications. Let's talk a little bit about calcium. So the need of calcium per day is 1,500 milligram, and as I told you, it enhances the treatment effect of other medications. It's best if we take this daily requirement of calcium to our foods because it provides other nutrients. But most of our patients, even in USA, they don't get enough calcium through their meals. So in that case, we need to provide calcium supplements. So calcium supplements again indicated for prevention and treatment, and it has come in various formulations. It might have various calcium salts. And also these formulations can have other necessary vitamins and minerals for the bone health. Namely, few of the calcium salts which are commonly available are calcium carbonate, calcium citrate, calcium gluconate, calcium hydroxyapatite. And when you are prescribing calcium supplements, we have to think about the bioavailability of calcium and whether the patient is using active receptor blockers, PPIs, and presence of acrolelia, especially in elderly patients, and number of tablets needs to achieve the desired dose and size of the tablet and form of the calcium that we are going to use, and very important cost of the tablets. So this shows the percentage, the concentration of calcium each of these commonly used calcium salts have. Calcium carbonate has 40% and calcium citrate 21%. Calcium carbonate is the commonly used calcium salt and it is inexpensive as well. The problem with calcium carbonate is that if the patient is having acromegalia or if the patient is taking PPI, you have to take it with meals, necessarily with meals. Otherwise, we have to think about giving the patient calcium citrate patients with having a meal or not wouldn't matter. Also, we can prescribe it to patients who are taking PPIs. Calcium gluconate and calcium lactate has lesser concentrations of calcium, and as a result, we will have to give multiple doses. And this is, we should remember that sometimes that reps come and tell that, they have this much of calcium in their preparations. But if you are taking the calcium tablets, if it is more than 500 milligram, the percentage of absorption is going to get reduced. So the maximum that you are providing at a time should be less than 500 milligram or 500. There are certain substances which can hinder the absorption of calcium, so we should not give them at the same time. And very important that certain medication also get affected with the use of calcium, especially in thyroxine. If your patient is on thyroxine, delay taking calcium tablets at least 4 hours. And they say better to take calcium tablets at night rather than in the morning, because at night there's more bone turnover. The other thing is vitamin D. At the treatment phase, we might need to give 1,000 to 2,000 international units of vitamin D, and we don't have to give vitamin D metabolites like 1-alpha, because unless the patient is having renal failure. And they say D2 and D3 equally effective, but not D2 and D3s are in preparations, but D3 has more benefits as a treatment for osteoporosis, because it's keep longer periods of time. So specific treatment includes this plethora of a lot of medications, but when it comes to GP and primary practice, I think bisphosphonate and denosumab are very important. So these charts provide how effective they are in reducing vertebral fracture, hip fracture, and other non-vertebral fractures. And these medicines I have experience with, and I will share some insights about those. Alendronate, very common, inexpensive in comparison to other medication. We have to give 70 milligram weekly, and it can reduce all the fractures, namely vertebral, hip, and non-vertebral fractures. Imandronate, common use in Sri Lanka. The advantage is you can go for monthly dosing, 150 milligram monthly, and then it can only shown promise in reducing vertebral fracture. So Lendronate is an IV preparation which can be used in patients who do not tolerate oral bisphosphonate. Denosumab may be for patients who have renal problems, because we cannot give bisphosphonates for those who are having eGFR less than 35. So denosumab will be indicated for those patients. We have to give it every 6 months subcutaneously. Those side effects, and there are common side effects. The irritation, we all know. That's why we ask the patient to take it on empty stomach first thing in the morning, and then we ask them not to lie down after taking the tablet. At least 30 minutes for alendronate, for ibandronic acid, it's 1 hour. And it's common to see that developing flu-like symptoms, musculoskeletal pain. I have witnessed that. I have advised my patients. And if you are giving alendronic acids, we will give paracetamol, especially with initial doses, in advance. And also we have to educate them that these symptoms are going to disappear. And when you are planning to give these medications, it's always better to give on Friday so that they will recover from these side effects during the weekend. And also, if they have any important event or any other work commitments, schedule it accordingly. There are serious side effects, but those should not be a barrier for you to start treatment, because osteoporosis is also a very big concern. Osteonecrosis of the jaw may be alarming, but it is very rare. So then the question of whether we should refer to the dental surgeon, no and yes, because if the patient has low risk, we don't have to refer them to a dental surgeon, and they just have to continue their routine dental care. But if the patient having an acute dental infection or any dental procedure coming up, we would have to get advice from a dental surgeon. Atypical femoral fractures is a common side effects problem with long-term use of bisphosphonate. So we review the patients at 3 years if they are taking IV, and at 5 years if they are taking oral, and if the risk is mild to moderate, we would give a drug holiday. So these are key takeaways. Osteoporosis is common, and even though it's silent, it can be serious. And GP have a pivotal role in managing osteoporosis, and we can use both FRAX and DEXA scanning, and start calcium and vitamin D in prevention and treatment. And I hope that I could give you some confidence, especially for those general colleagues, my general practitioners, and who are engaged in primary care about osteoporosis. And I thank Menopause Society of Sri Lanka, President and Expo, members and the organizing committee, Dr. Tivanka Munasinghe recommending me to do this presentation. Also my fellow co-presenters for their insightful contribution and collaboration. Thank you so much.
Thank you, Dr. Hidika, for that interesting talk on bone health management, of practical approach to bone health management in menopause. I think we have, even though he has exceeded, he will take an extra few minutes, but we have about another 5 minutes. If the audience wants to ask questions, we can take 1 or 2 questions from the audience. Audience, yes, can we have a mic? Mic,
Thank you very much for all the 3 presenters. My question is it recommended to give generally for all the postmenopausal women calcium supplementation as a prevention of osteoporosis and osteoporosis related fractures, and how it should be given like as a universal treatment?
Actually, it is the we have to make sure the patient is taking adequate calcium and vitamin D. So it can come from nutrition, that is foods, and then the vitamin D from daily sunlight. But if you think that it's lacking, we have to additionally provide that. So most of the time in postmenopausal women and with our daily patients, people are not exposed to sun, so we might have to give it to prevent.
Any other questions? Give the mic. In the absence of any further questions, we wind up this session. Thank you very much. I would thank all 3 speakers for the excellent speeches. Thank you.
Thank you so much. I invite the chairpersons to award the certificates to the speakers. And I invite Dr. Hemantha Pereira to award the certificates to the chairperson. Thank you so much. We'll now move on to a different aspect of menopause-related health issues where Dr. Aparna Henke